welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Our first presenter is going to be Paige Fields. She's a PGY2 critical care resident at UChicago Medicine, and today she's going to be presenting on the impact of Desmopressin on hematoma expansion and patients presenting to the emergency department on antiplatelet therapy.
Thank you all for the introduction, and thank you everyone for joining. So I first wanted to go over just a couple objectives for the presentation, including a quick review of the pathophysiology behind intracerebral hemorrhage, which throughout the rest of the presentation I'll refer to as ICH, and understand how antiplatelet agents might influence its progression. And then we'll shift to desmopressin, what it does, how it's been used in this setting, and then most importantly, what the literature tells us about its role. So intracerebral hemorrhage, or ICH, is a devastating form of stroke characterized by bleeding into the brain parenchyma. Although this form of stroke only accounts for around 10% of all strokes in the United States, mortality from ICH remains as high as 30% within 30 days. The main inciting causes of ICH are hypertension, cerebral amyloid angiopathy, and anticoagulation. And the pathophysiology is rather complex, but overall encompasses hematoma expansion, mass effect, and then a secondary injury. Patients that are treated with antiplatelet agents are more likely to experience ICH with severe clinical presentations, and data has shown that up to 30% of patients that present with ICH are being currently treated with antiplatelet agents as well. Antiplatelets have been associated with a larger baseline hemorrhage volume, higher risk of hemorrhagic growth, and then risk of hematoma expansion. The concept of time is brain is relevant for the management of ICH as well. Even in the absence of a specific treatment, ICH is a neurologic emergency. So the volume of the clot at the time of hospital admission is a predictor of the functional outcome at 3 months. And so that's known as the hematoma expansion. In general, when it comes to the acute management of ICH, our primary goal is to limit hematoma expansion, as that's what's most commonly linked to poor outcomes, especially early on. Expansion of the hematoma causes tissue destruction beyond what is caused by that initial clot. And so there are a few main strategies that we lean on. So first is blood pressure control, as both high and low blood pressures after ICH are associated with poor outcomes. There's hemostasis, which is where things like platelet transfusions, procoagulants, or desmopressin may come in, especially if the patient's on an antithrombotic at baseline. And then lastly, there's neurosurgical interventions for select patients, like those that have a large lobar bleed, herniation risk, or an interventricular extension that can be drained. So antiplatelet agents, also known as platelet aggregation inhibitors, are a subset of antithrombotic agents that inhibit platelet aggregation and reduce the formation of platelet-rich thrombi in the arteries. So on this slide are some of the more commonly used antiplatelets, and they inhibit platelet aggregation by targeting different sites. So aspirin blocking formation of thromboxane A2 by irreversible inhibition of cyclooxygenase 1 that results in permanent platelet inhibition. We have clopidogrel and prasugrel, which prevent platelet activation by antagonizing P2Y12 receptors, which in turn inhibit binding with adenosine diphosphate. And then these agents irreversibly bind to P2Y12 receptors, and the inhibition is maintained over the platelet's lifespan, compared to ticagrelor, which is a reversible inhibitor. Cilostazol and dipyridamole are phosphodiesterase inhibitors that we won't focus on as much today, but more so for completeness of the antiplatelet agents available. And so overall, this table summarizes the key differences between the most commonly used antiplatelet agents. And you can see how each agent varies in terms of degree of platelet inhibition, half-life, and reversibility. And so, as noted on the last slide, but the notable difference between these agents is seen with ticagrelor, which is a reversible inhibitor. So ICH is the most serious bleeding complication related to antiplatelet therapy. The overall risk of ICH with each of these agents varies slightly based on the medication used, but in general, our P2Y12 inhibitors tend to be associated with a higher risk due to their more potent platelet inhibition. Besides specific agent use, other important risk factors that should be considered when assessing the patient are increased age, concomitant anticoagulants, and uncontrolled hypertension. Reversing the effects of antiplatelet agents in the setting of bleeding is challenging since there are no true reversal agents, but platelet transfusions have been proposed as a potential strategy to overcome the antithrombotic effect of antiplatelet agents for patients with ICH. So the mechanism is pretty straightforward, where platelet transfusions provide the additional platelets to the bloodstream and improve hemostasis by promoting clot formation at the site of the bleed. In terms of efficacy, studies show that platelet transfusions can be effective, but they might work best when they're given early and in patients who still have viable platelets. The PATCH trial, which randomly assigned a group of patients to receive platelet transfusions, overall had twice as high mortality and higher rates of disability in the platelet transfusion group than those that did not receive transfusions. So if a platelet transfusion is given, it should be ideally administered after 3 to 5 terminal half-lives of the antiplatelet agent used to avoid the pharmacologic inhibition of that transfused platelet. And then again, due to the reversible nature of ticagrelor, this mechanism likely cannot be reversed with platelet transfusions. For desmopressin, this is a vasopressin analog, which promotes platelet adhesion to the endothelium by increasing our endothelial release of von Willebrand factor and factor VIII. Von Willebrand factor, in return, enhances platelet adhesion to collagen and may also bind to platelet glycoprotein 2B3A receptors. Desmopressin also enhances formation of procoagulant platelets and platelet-dependent thrombin generation. And so since the 1970s, desmopressin has been used to prevent bleeding in patients with von Willebrand factor deficiency and hemophilia A. And it's also been shown to reduce bleeding time and normalize hemostasis in patients with uremic bleeding undergoing surgery. The dose of desmopressin is between 0.3 to 0.4 micrograms per kilogram, given as an IV infusion over a short duration, usually between 30 to 60 minutes. Some adverse effects to be aware of would be from the antidiuretic effects of the medication, so that being hyponatremia, hypervolemia, and then decreased urine output. Arterial thrombosis is a risk factor, but mostly theoretical. Most studies evaluating desmopressin for antiplatelet-related ICH have been of retrospective design with small sample sizes. I've included a handful of these trials here on this slide, and as you can tell, they're all smaller in nature, but they do have the same primary outcome of hematoma expansion or growth for the most part, besides our first study, which the first study was just an exploratory analysis that was looking at improved platelet aggregation assessed by the platelet function assay. So in general, you can see that the data behind using desmopressin in ICH is rather limited, kind of pushing us in the direction of why we're here today. Despite the lack of evidence from dedicated clinical trials, due to the overall safety profile of desmopressin and its relatively low cost, guidelines do give a recommendation for the use of desmopressin. So the Neurocritical Care Society and the Society of Critical Care Medicine do suggest consideration of desmopressin at a dose of 0.4 micrograms per kilogram in antiplatelet-associated ICH. The American Heart Association and American Stroke Association don't give us specific dosing for desmopressin, but they say it can be considered to reduce expansion of hematoma. But overall, as you can see, it's conditional recommendations with low quality of evidence. So this brings us to the study we're evaluating today. So this is the impact of desmopressin on hematoma expansion in patients who present to the emergency department on antiplatelet therapy. This was published in the American Journal of Emergency Medicine in March of this year. And as you can see, a slew of pharmacists as authors on this study. So the purpose was to determine if desmopressin impacted hemostatic effectiveness in patients with antiplatelet-related ICH presenting to EDs across the U.S. The hypothesis was that there would be no difference in hemostatic effectiveness with or without desmopressin. So this was a multi-center retrospective observational cohort study. It was conducted across 11 EDs in the U.S. that participated in the Emergency Medicine Pharmacotherapy Research Network. And the patients were included if they presented between January 1st, 2017 through May 1st, 2021. To reduce the potential imbalance of baseline characteristics between patients with and without desmopressin, the authors used propensity score matching. And so the propensity score was defined as the probability of a patient receiving desmopressin given their age, sex, NIH stroke scale score at baseline, and ICH score at baseline, as estimated using a multivariable logistic regression model. So the patient population included adults that were greater than or equal to 18 years of age that had a primary diagnosis of ICH, which was classified as either an epidural hematoma, an intraparenchymal hemorrhage, subdural hematoma, or subarachnoid hemorrhage, and on at least one antiplatelet agent prior to admission. Exclusion criteria were mainly for no follow-up head CT within 24 hours of initial CT, if they had been previously enrolled in the study, pregnancy, if there was transfer from an outside hospital, and the time to intervention was greater than 12 hours, concurrent ischemic stroke, neurosurgical intervention within 12 hours of admission, which did not include EVDs, if there was an INR of greater than 1.7 secondary to a non-anticoagulant related coagulopathy, there's no antiplatelet agent on their home med list, they had an isolated traumatic brain injury, or if they had missing information. The primary endpoint was good or excellent hemostatic efficacy within the first 24 hours. And this was given a leeway time of 6 hours following ICH. And this is according to the Scientific and Standardization Subcommittee on Control of Anticoagulation of the International Society on Thrombosis and Hemostasis criteria. So good or excellent hemostatic efficacy was defined as less than or equal to 35% increase in hematoma size. And this was assessed via brain imaging that was done by expert physicians who were blinded to the desmopressin status. And they quantified hematoma volumes using a 3D slicer software. And to eliminate subjectiveness in assessments, these physicians underwent multiple case-based training sessions to ensure competency and uniformity of data collection. Secondary endpoints included discharge modified Rankin scale score and National Institute of Health stroke scale score. Other secondary endpoints included in-hospital and 30-day mortality. And then for safety outcomes, this included thromboembolic events at 7 days, which included ischemic stroke, myocardial infarction, or venous thromboembolism, and then the serum sodium nadir within 3 days. So the study initially screened a total of 1,408 patients, of which 1,084 were excluded. The most common reasons for exclusion was no follow-up head CT within 24 hours, then isolated traumatic brain injury, then concurrent ischemic stroke, and then neurosurgical intervention within 12 hours of admission, and then missing information. So overall, this left 324 patients eligible for analysis, 45 patients receiving desmopressin, and then 279 patients not. And from there, they used the propensity score matching to create a final 1-to-4 matched cohort where there were 35 patients in the desmopressin group and 140 patients in the non-desmopressin group. So baseline demographics were similar between groups, apart from race, where there were more Black patients in the desmopressin group compared to the control group, which was statistically significant. Comorbid conditions were similar between groups as well, apart from end-stage renal disease, which is more common in the desmopressin group, and cancer. As for labs and vital signs, patients in general had similar systolic blood pressures, INRs, coagulopathy, so hemoglobin and platelets, and similar sodium. And then patients in the desmopressin group had a slightly higher baseline serum creatinine that was not significant. So the most common type of ICH was intraparenchymal hemorrhage, which was 100% in both groups. Baseline ICH score was similar between the two groups. And then hematoma volume was significantly different between the two groups. So in our desmopressin group, the average hematoma volume was 27.6 milliliters versus 2.1 milliliters in the control group. NIH score was slightly different between the two groups, with 11 being in the desmopressin and 6 in the control. And most of these patients were on aspirin prior to admission as their antiplatelet agent, with clopidogrel being the next most frequently used antiplatelet agent at around 15%. There were no differences between groups in terms of concomitant hemostatic agents. The most common hemostatic agent was 4-factor prothrombin complex concentrate in both groups, which was 22.9% in the desmopressin group versus 14.3% in the control group. Vitamin K was the same in both groups. For blood products, this was similar between the groups, except for more packed red blood cells being given in the desmopressin group. So it was 11% in the desmopressin group versus 0.7% in the control group, which was statistically significant. More patients in the desmopressin group also had neurosurgical interventions, including burr hole placement and craniotomy. So for the primary outcome of good or excellent hemostatic efficacy, it was similar between the two groups. So 74.3% of patients in the desmopressin group and 85% of patients in the control group had a difference of 10.7%. There were no differences in the change in hematoma volume or maximum thickness or hematoma expansion of less than 20% as well. And then you can see the logistics of patients in the desmopressin group. Their average dose was 26 micrograms, and this was around 0.3 micrograms per kilogram on a weight-based dosing regimen. Median time to administration was 163 minutes with an interquartile range of 111 to 356 minutes. For our secondary outcomes, so patients in the desmopressin group and the control group had the same modified Rankin score at discharge. Patients in the desmopressin group had higher median NIH stroke scale scores at discharge. So this is 11 versus 2.5. That was not significant, but as you can see, the differences there. And then there was overall no difference in discharge disposition or in hospital or 30-day mortality between the two groups. For safety outcomes, the overall incidence of thromboembolic events at 7 days was low and was not different between the two groups. And then serum sodium nadir was actually the exact same between the two groups at 138, so no difference in any of the adverse events that were recorded. So overall, the author's conclusions did not demonstrate improved rates of good or excellent hemostatic efficacy in patients receiving early desmopressin for the treatment of ICH. But additionally, desmopressin was not associated with an observed increased risk of adverse events. So my critique and overall assessment of strengths and limitations of this study. So strengths-wise, this is a large multi-center data set. So this data came from 11 emergency departments, which increases our generalizability across different practice settings. Also blinded imaging review to assess hematoma volume. So whenever they used the 3D slicer, it was formalized to try to limit the subjectiveness of each of those assessments. And they also evaluated clinically relevant outcomes, both radiographic and clinical. So thinking of hematoma expansion, mortality, thrombotic events, rather than just surrogate markers. Some limitations. So there were baseline differences despite matching. So the larger hematoma volume and higher NIH stroke scale in the DDAVP group is something to take note of. Also, this population was predominantly aspirin as the antiplatelet agent prior to admission. So it does limit our applicability of dual antiplatelet regimens or some of our P2Y12 inhibitors as well. Additionally, the PTA antiplatelet adherence was unknown, so unable to confirm the last time that the dose was given or if they're overall compliant to the regimen prior to admission. There's no report of blood pressure ICP management, which we've learned that both affect hematoma growth as well. And then overall, there's no platelet function testing performed. So something to consider whenever we look back at those initial studies, that some of them did look at some of those platelet function assays as well. But overall, so take-home points for patients with spontaneous ICH on antiplatelet therapy, we do have current limited reversal strategies. So desmopressin did not demonstrate a clinical or radiographic benefit in patients with antiplatelet associated ICH. Despite guideline recommendations, routine desmopressin use is rather up to the provider and hospital specifics of whether or not a risk-benefit profile can be seen. And so overall, the study contributes to the growing body of real-world evidence, questioning desmopressin's role in ICH reversal. And so it kind of reinforces the need for prospective randomized control trials to further evaluate timing, dose, and ideal patient population, and maybe include some more of our other antiplatelet regimens as well. And so in general, as pharmacists and clinicians, it's our job to quickly evaluate reversal strategies and avoid automatic use. We don't see a clear benefit. But with that, I will open up to any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.